Good afternoon and welcome to today's program titled Revenue Cycle Management, Keys to Financial Health. I'm Julia Brown, Associate Editor of Behavioral Healthcare. Today's program is sponsored by the Echo Group. Thank you to our sponsor and to everyone in our audience for giving us your time and attention today. Before we get started, we have a few housekeeping details. Each window on your screen can be moved by clicking and dragging, or enlarged and minimized by clicking the icons in the top right corner of each window. Please use the Q&A area to the right of the slides to submit a question at any time. You do not need to wait until the end of the presentation. If you cannot see this area, simply click the red Q&A button. To download a copy of today's presentation, please click the link in the resources area in the lower left of your screen. If you have any technical issues during the program, please click the yellow help button to troubleshoot the issue. Finally, you can also tweet during today's webinar via the Twitter widget by clicking on the blue Twitter icon at the bottom of your screen. Simply click the Post and Authorize buttons to log in to your Twitter account and begin sharing automatically at the event hashtag BHLiveWebinar. At this time, I would like to introduce the speakers for today's program. Ben Pease, Chief Financial Officer, the Echo Group, and Joe Viger, VP of Business Development, the Echo Group. Ben Pease has held a leadership position that helped grow an RCM company from $50 million in collections to over $4 billion, representing a revenue growth for the company from $6 million to $60 million. Ben's experience also includes RCM practice management consulting work, helping his clients become more clinically effective and financially strong. Ben believes an organization's administrative efforts must emphasize financial viability and allow clinicians to focus on providing the best possible care and improved outcomes. Joe Viger joined Echo in 1999 with a varied behavioral health background. These areas include experience in case management, managing residential systems, and community-based treatment teams with diverse populations. Joe has served in many roles at Echo, including consulting, professional services, and business development. He is also on the board of the Software and Technology Vendors Association. Thank you both for taking the time to speak with us today. And with that, the audience is yours.
Thank you for joining. This is Ben Pease, Chief Financial Officer of the Echo Group. And I'd like to, just as a point of reference, talk a little bit more about my background in both the behavioral health and medical space. I have pretty extensive knowledge, but to be honest, I'm more familiar with medical practices in the background. That's where the RCM focus was, and at mental health behavioral hospitals. So I kind of bring the dynamic of the financial component piece. And Joe, on the other hand, brings us his varied background, and so you'll see that interchange between the two of us, looking at things from different perspectives.
Hi, folks. This is Joe. Yeah, that's it. We won't be point counterpoint. We won't get there. But Ben and I definitely complement each other well. As Julia brought up and introduced me with about a 15-year social work background, that tends to be the lens through which I look at what Echo does and, that agency perspective. And so I'll offer some comments today as it relates to some of the RCM details that kind of round out that picture, I think, as it relates to organization management and the way folks might think strategically about running their organizations, and some of these keys to financial health can help you do that. So let's take a minute and just introduce you all to the Echo Group. The Echo Group was founded in 1980, so we've worked in behavioral health for a long time, and folks may be familiar with us. But in case you aren't, just 1 second on who we are. The Echo Group is an organization that develops enterprise-wide software applications specifically focused for the needs of behavioral health organizations. We have customers in 40 states, so we have a broad footprint around the country with a lot of different kinds of organizations that we are happy to call customers, including straight ahead community mental health centers, organizations that work with folks with intellectual and developmental disability, folks that provide substance abuse treatment, organizations that provide family services, and all various mixtures in between. In that way, we work with folks around electronic health records and billing systems. We also work to deliver them either through a self-hosted arrangement or a SaaS contract, so some different options with us. And we also are unique in that we do have a division of our company that is exclusively focused on revenue cycle management. That is specifically a team of folks who work on producing bills and getting payments for our customers, and that is part of the organization that Ben heads up. So that's a little bit about us and where we come from. We're excited to be here today to present some information to you. And with that, I'm going to turn it back to Ben, who will start driving us through the content for today.
Thanks, Joe. So I'd like to speak today about defining a little bit what revenue cycle management means. Most people, when they think of revenue cycle management, they tend to think of just billing. How do I get claims out the door? Revenue cycle management is really much more beyond how do I get claims out the door, but rather is a holistic view to how do I secure the financial health of an organization, which might include eligibility, credentialing, software, appointment scheduling, the whole gambit that handles that kind of back-end approach to the administrative functions of people's businesses so that they can focus, and organizations, so they can focus on the clinical piece while we focus on the administrative piece as it relates to how do we collect money, grow the business, get good data to make great decisions, and wise business outcomes are spawned from that. The second element that we'll talk about a little bit is key performance indicators and what's important about them. And I will teach you 3 KPIs today that are essential to your long-term financial health. And those 3 that I'll teach you about are days in AR, collections per clinician hour, and collection per client hour. And those really are the 3 that I'll teach you how to calculate and why they're important to your overall financial success. So as we know, 10 years ago, the complexities with billing were far less. They're not, with Medicare changing a lot of its rules and states changing the way that they look at Medicaid and payers getting more complicated, really it's pay for performance has become and kind of taken over a lot of the thought process behind how reimbursements are structured. This has led to complexity. Complexity has made it a lot more difficult to just simply send bills as a happenstance, but rather now you have to have knowledge, expertise, and you have to really have someone focus in on how you bill. So before everyone turns off, I know everyone in every key performance leadership council talks about Peter Drucker and Edward Deming. The elements here that's really important and salient to the conversation overall is the fact that if you in revenue cycle management and in your financial, when you're thinking of billing and collecting those dollars, don't measure your results, like Mr. Drucker says, if you don't measure it, you won't manage it, and you can't improve it. And that's really the key here, takeaway, I hope, from this presentation as I teach you these 3 KPIs, that you'll use these KPIs to help manage the organization and not be managed by the claim process, and really be more proactive and less reactive in that process. And then the second quote's really just more of a fun little quote. It made me laugh. In God we trust, all others must bring data. So from a finance perspective, that's something that kind of makes us chuckle, because data is really near and dear to my heart. It's how I drive my own business decisions and the decisions of the organizations that I work with. So KPIs are really important to get back to the data. And the first thing you're doing, so let's say, for example, you want to establish services per client hour as a KPI, a key performance indicator, because you want to drive more revenue to expand your facility, let's say, to service 5,000 more individuals. This would be a great indicator to help manage that, because you would be able to state the goal clearly. I want to expand my services to an additional 5,000 people. That KPI should lead to action. So in this case, if you use collection per client, it would drive you to make decisions on, okay, this service is funding X, and this other service is funding Y. And the delta between them can help support the additional facility costs, maybe the additional clinicians. Everyone has accountability. So from the clinician standpoint to the board of directors, everyone has a job to fit to support that goal of helping to grow services to an additional 5,000 people. Quantify your outcomes. So if you can't really put a quantity number or some metric around it, then you can't really drive it towards action. So it has to be able to be measured and quantified. And you need to really sit down and review the metric regularly. Talk to the staff and talk to the board of directors, and everyone should be online that we're looking to expand our services to the additional 5,000. And remember, the organization should contribute, everyone in the organization should contribute to the overall financial success. That's really one of the key driving factors, should be which role does everyone play within that organization to help support that goal.
So now, one of the things we're going to integrate into today's presentation is a series of poll questions. And so we're going to kick this off right now. And the first poll question is going to be, do you use financial KPIs to track RCM performance or your billing performance? And a simple yes or no will do. If you'll take a minute and offer us some feedback on that, we'll carry on from there. So just take a second and help us out with some data. All right, so we have, through the magic of technology, the ability to auto-calculate these answers, and I'm like a child as I look at this, and I'm fascinated by the data popping up there, and we see that we have a little more than half of you saying you do currently have a sense of key performance indicators as you look at billing performance and RCM performance in your organization. So it'll be interesting to see of the 56% who are currently doing that, how some of these things resonate with them, or if we can offer you some new insights. And for the 43.6%, hopefully we'll give you some new things to implement very quickly in your organization to give you some deeper insight. So let's carry on. We'll revisit this data later.
So best practices, KPIs, and RCM. The three key KPIs that I'm going to teach you today, right, just to reiterate, is days in AR, collections per clinician hour, and collections per client hour. And that's really what we're going to focus on. And the first one that I'm going to teach you about and how to calculate is days in AR. And just as a point of reference in the graph, you can see that the green line is the 2014 result and the blue line is the 2013 results. So as we're looking at the 2013 results, we can see here that in August of 2013, we had a spike in days in AR. And in 2014, it was about half. So the fewer days, the lower the number, the better it is in the organization. It means that you're speeding it up. And this is one of our customers that we did some actual results. So this is prior, the blue line is prior to them using our software. The green line is, software and service. And the green line is after they used our software and service. So how do you calculate days in AR? Pretty simple calculation. You take your ending AR balance divided by your average daily charge, and it equals your days in AR. So, for example, if the government, let's say the state in October decides to cut funding because they've run out of dollars, and they reduce your average payment, that charge, from $1,000 to $500, it would double your days in AR. It would take it from 100 days to 200 days. Likewise, if you sped up your collection process and got more payments quickly, it would reduce that $100,000 ending AR balance, let's say in half, to 50, which would speed up your days in AR from 100 to 50. So why does that matter? I hear frequently from people, if I'm going to get paid for it anyways, why should I care? If I get a payment today or I get a payment in 6 months, why does it really matter? I think this is really kind of not a question of the chicken or the egg. Really what it's a question of is the organization, so let's go back to that goal of expanding services to 5,000 people, needs money to help fund those additional services, maybe to expand the building, to expand other items. So it's really important because that's like a pay increase. When I reduce it from 100 to 80 days, that's a $20,000 check that I've just added into my pocket. And that's really what we're talking about. It can fund the service expansion.
And, an interesting thing there, one of the things I've been fortunate to do is a lot of consulting with our customers from Alaska to Florida. And when you talk to folks, there are a lot of things out of control in your billing process and in your revenue cycle management process. The payer's going to exhibit behavior you can't control, like when they actually are going to cut you a check for a claim you sent them. The payer's going to change rates on you. The state is going to change service definitions, or Medicaid is going to reformat something. There's just a lot of things you have to contend with. But one of the things you frequently can get at, sometimes people forget that they do have the ability to grab tight of it and make a difference with it and have a positive impact on their organization as a result, are certain timelines in the billing process. And this is one of those, is that days in AR. How can you drive that down? Just like how you can look at the date of service versus the time the claim was submitted. Hopefully your information system can provide you that data, and then you can look at that and say, is it 2 days or 2 weeks? And if it's 2 weeks, we're bearing a high cost for that money, and we want to shorten that span to be 2 days. And that extrapolates into other things like standards of care around timely documentation. So I guess one of the points I'm trying to make here is we're talking some pretty hardcore financial metrics, but they seep into all areas of how you run your organization. And so it's about the financial health of your organization, but it's also just about the soundness of the operations of your organization.
Yeah, thank you, Joe. So I think to think about, when we talk about days in AR, we're calculate this at a 50,000-foot view, but you can drill it down even into lower segments. You can look at your days in AR for Blue Cross. You can look at your days in AR for every payer source you have. So really, you should think about how you can do that. You can drive it down at a facility level, and you should look for getting that type of data out of your software and be able to really drive the business based on the information. It's not that you're going to make clinical decisions to maximize your financial necessarily, but what it is to speak to is your ability to be able to fund the services that you need to be able to do. So when you're looking at this, how do you improve days in AR? The best practices to improve days in AR is really consistent follow-up is a key one. Continue to drive to policies and make sure that they're following up. There's been a study by HBMA, which is the Health Billing Management Association, kind of for billers and RCM companies. It's kind of the trade association to turn to. And they did a study, and they found that between 20 and 30% of all denials were never followed up with. That's a staggering number. That's money that you're leaving on the table that you've earned. You know, eligibility is an easy way to follow up on it. Make sure that you have policies and procedures and your software supports the ability to check eligibility. To Joe's point, there was another element. You can control how long it takes your clinicians to enter in the service documentation that they need. That's another thing that you want to speed up, because as you wait longer, it takes longer and longer to process information, because 3 weeks to enter information, you forget what happens.
Just looping back to eligibility, you know, that's definitely an opportunity to bring a lot of bang to the table as it relates to this days and AR issue. And it's also a place where you can leverage automation and technology and tools that can make that faster and easier and seamless and take any sort of human error out of the process. So, for example, the HIPAA-defined transaction of a 270, 271 is a potential option as it relates to checking eligibility. Many systems can facilitate that. Nationally, we've seen some states don't really return meaningful data around that transaction. We know that's definitely been a problem to adoption, is some payers just aren't really honoring the data the transaction requires. But if you have that opportunity to take advantage of it, I think it's an important one to look at because, again, then you have an automated eligibility checking process that enhances your operation. The other thing is, in some states, an example for us is in California, we have a direct connection to eligibility checking systems at the state Medicaid's office, and we can bring that into our system on a regular basis, and people can on a daily basis understand folks' eligibility status, which means you can be much more clear about, on a given day, the consumers you're seeing and whether they're in a position of having a valid insurance to be paid for the claim you're pursuing. And again, that's going to impact your days in AR.
Yeah, thanks, Joe. The other item is really, and probably the key and the most difficult item, is really how you track and establish a baseline for your denial rates and then drive improvements in those denial rates. And the best way of really looking at that is at a payer level. So you want to look at Anthem Blue Cross, and you want to make sure that all your claims are being processed by Anthem. Because let's say in an example is that Anthem hasn't paid you. You've looked at Anthem and it turns out that the claim was a valid claim, the person had insurance, but Anthem uses a TPA to process. They're a third-party processing agency to handle those claims. And so you didn't send it to the TPA like you were supposed to because you thought you were supposed to send it to Blue Cross. Likewise, staff. You know, is there a particular staff that maybe typically has higher denial rates? Is that due to the fact that maybe that particular staff isn't documenting things well or is using the wrong type of codes? You know, or is it a service level? Is there a particular service that you provide in which you're not being paid for? So those three levels of data points you really want to drive into in order to understand what your denials look like, where they're coming from, and how you can prevent them.
I think, you know, you can get pretty fine-grained on some of this stuff, and ideally you have information systems supporting this, that when you enter a zero payment, a denial of some sort, that you have the ability to grab a predefined value of some sort, a value that you've standardized, or a number of values you've standardized, I should say, that define why the denial has occurred. So Ben's defined some broad categories. You know, you might get more granular and offer up a code that defines the denial reason was based on service authorization, or another one that's based on timely filing, or different things that you might be concerned about managing. And if you can do that and you can look at those denial trends, then you can start to understand where where to apply your valuable time. No one has excess management in the behavioral health organizations I work with. So you have the ability to apply the management resources you have to manage specific issues that are costing you the most money or incurring you the most pain. And if that is timely filing, then you can focus the team on getting those claims out the door in a timely way. If it's service authorization, you can turn the ship that way. So that's a real important piece to be able to pull back that layer and better understand that and inform your operations. The other piece to this is tracking denials also gives you insight into what essentially is free care, and knowing what's generating that free care in your organization. And once you do that, you can begin to peel back layers there to understand what programs have the highest denial rates and what programs therefore are delivering the most free care. And at that point, you can begin to make some strategic decisions. So if you run a community support team for high-risk adults and you give a lot of free care there, that make total sense to you as an organization because it's congruent with your mission. That population needs your service. That population it has no other place to get service, and it makes all the sense in the world that you deliver that at any cost. That's important to understand so you can turn to other parts of your organization and make sure you have offsetting revenue to support that program from other places. And that's going to make your organization vital and promote the well-being of your organization financially so you can maintain levels of care long term. Conversely, you may not know that you have such a level of free care in a given program and realize that isn't really a good place for your organization to be investing its time and money and decide to discontinue that program's services. And that's okay if that's congruent with your mission. So peeling back these layers gives you some real strategic data to act on as a management team, starting with this denial information and then building out the rest of the story with other points of data. And lastly, I guess I'd also offer that that free data piece, that free care piece is important because I know in my experience doing different things in the behavioral health world, that free care can be quantified and can be put into grants as matching funds, and it's a great way to demonstrate your commitment to the community as you market your services to the community, et cetera, and probably many of you have experienced that. But this is where it kind of starts, is understanding those denials, understanding the free care, understanding what drives that denial. Is it internal to your organization or is it an external force that you maybe can advocate to change, et cetera, et cetera. I'm sorry. So we have our next poll question, and I think folks did very well doing the last one, so I'm sure you'll do fine on this one as well, and that is, do you track days in AR? Yes or no? So if you could help us with some information there, if you perform that baseline financial metric in your organization and use it to manage, help us out with some information. We'll move on to the next topic in the webinar today. We've done polls before in these webinars. I always feel like we need to ask for the Jeopardy music. So we now have our data, and we have 60%, almost 61% of you that do in fact track days in AR in your organization, and about 40% that do not. So that's interesting. That's a pretty core metric, and so it's interesting to see the level of adoption there.
So the next metric we're going to teach you about is collections per clinical hour. So we can see here, the higher the line is, the better the result is. So the green line here represents 2014. The blue line represents 2013. So we can see that we can see your client. So collections per clinical hour, and this is how you calculate collections per clinical hour. So how you calculate it here is you take the total collections divided by the hours worked equals the collections. So in this example, we see that $10,000 and 160 hours worked equals $62.50 collected per hour. So this is a good measurement to measure how well your clinicians are doing, one, as an organization at that 50,000-foot view, and two, you can break it down into the smaller increments and look at your master level clinicians or your therapist, or you fill in the blank, your caseworkers, and see how they compare against each other. And what that leads to is then for you to be able to understand, maybe for a case manager managing cases, one's driving 2 or maybe 30 minutes between appointments. And so there's a lot of driving time that goes into that billing number, whereas another case manager may have a very high case rate and billable rate because their cases are 15, 20 minutes apart from each other or 5 minutes down the street. And so you can make a decision in the organization and decide, okay, is there a way that we can redirect and adjust? Maybe we can move some cases around to help adjust for this. At the bare minimum, at least have some exposure to what that is. So, so we can see here that we need to look over justifying their compensation, like I just said, and so how can we improve this? Some of the best practices to consider. As we mentioned earlier, one of the ways to improve this is to make sure that service level documentation is being turned in, done, submitted on a timely manner. Another way is to make sure that all our clinicians are credentialed and that we have strong credentialing background. Another is the documentation and code review. I would recommend that once a year, at a bare minimum, you engage an outside agency to come and review your documentation, review your codes, and make sure you're using the right level of documentation. For example, you may have Blue Cross and you may do half an hour of therapy, and that's traditionally what the clinician's used to doing. But for the last 5 or 6 clients that he's seen, maybe he's actually been delivering an hour of consulting services and still using the old codes. And really what you're looking here is to achieve the best payment outcome. And that's really what you should be driving to, is using that best payment outcome.
Another example here that's been a big deal in our business in the last year with a lot of our customers has been the whole migration to E&M coding. And so it's drastically changed how people are managing some of their psychiatric evaluation visits through the E&M structure instead of what formerly was a much simpler coding operation. So as Ben said, regular review of that process becomes really important in that changing landscape, to ensure that you're doing it properly to maximize revenue, but also to manage risk. If you're not doing it right, you're going to be subject to payback. So having an impartial review of that, and particularly in times of change, can be really valuable.
Yeah, thank you, Joe. I agree. The other thing we have to look at here is just some ancillary things. Looking at a comparison amongst the services can help out there. Looking at payer negotiation, there was an example of a urgent psychiatric center that we helped out, and in that center they hadn't done credentialing and, renegotiated their rates with the payers in 7 or 8 years. And the payers kind of expect you to come back and ask for more money at the term of your contract. Some vary. Some are 24 months. Others are 36. Some are 4 years. It really depends on the payer. But at that end of that term, you should reach back. In this particular example, we were able to get them 25% increase the first year, and then over the 3 year of that contract, it was a 36% increase. But the sad reality is they should have been getting those increases all along the road, and they left money on the table for the services that they did.
And the last point we have here, speaking to integrated care, many behavioral health organizations that we work with in the last year, 18 months, maybe even a little longer, have started to explore or ramp up aggressively abilities to address the primary care needs of their behavioral health consumers. And for some folks, that's been a partnership opportunity. For other folks, they've actually built the capacity to deliver those services, document those services, build those services. As it relates to this collections per clinician hour idea, one of the things I think behavioral health organizations can benefit from is looking at what new service opportunities exist that advance the mission again. And that's one of the reasons people have become so interested in integrated care, is it advances the mission to treat people in a more holistic, strong way. But what financial opportunity exists for you in doing that? And does that inform your strategy moving into integrated care? As you look at this metric of collections per clinician hour and compare rates for integrated care style services, primary care services, you might realize this is one of the ways you can positively impact that with the given opportunities you have currently. And so that's something you don't want to miss and you want to be thoughtful about, and this data can help you do. The other thing just to share in regards to this idea of collections per clinician hour is, this, as I've met with organizations over my tenure here at the Echo Group, most everybody tracks productivity in one form or another. Frequently, it's tracked as a billable hour. And so you assign a billable hour to a standard to a service provider, and it might be 19 or 20 or 21 hours a week or whatever it might be. You might even pay them a bonus for hitting certain productivity targets. That's not uncommon anymore that should happen. But one of the things that is less common is taking it to the point of this metric and drilling down into individual staff where you're actually looking at collections per clinician hour. And that idea of, staff person A performing 10 billable hours might generate $500 in revenue for you, while staff person B has the same level of productivity, 10 billable hours, but in that time produces $650 of revenue for your organization. That may not be a good or bad metric. That's for you to figure out. Again, it's kind of like we've mentioned earlier, what's your mission? So the reality is staff person A might be working with staff that generally have lower reimbursement rates because of the type of service or because of the type of payer that supports that service or that population. Whereas staff person B works with a population that generally garners more money. And that may be perfectly fine and okay, but you don't know that unless you start looking at this kind of data. And when you look at it, you might determine, gee, we want 10 more like staff B because they generate more revenue for our organization and we need that revenue right now. Or you might decide, staff A does a great job because they support a needed population for us. So again, pulling back the seams of some of this allows you to be much more strategic in how you think about some of your program decisions. So we have another poll question for you all, and big surprise, we're curious if you do track collections per clinician hour. So if you could help us with that, we'll take a look at the results. So far in this process, we've had people on the high side of 50% in the last two questions in terms of using these metrics in their organizations. So some decent adoption, but not to say complete for sure. So let's see what our results are here. So we flipped this one. This one is far less common, collections per clinician hour.
Yeah, so I think that the key here, takeaway for me, for the the audience here is to really think about adopting that at a higher rate, and think of the advantages that that can bring to the organization to grow the revenue stream and to make sure that we're really tracking productivity that matches reimbursement, not just productivity that matches time worked. So the next metric that I'm going to teach you about is collections per client hour. So we can see here in this graph that the green is the 2014 results, and the blue, once again, is the 2013 results. And once again here, the metric, the higher the metric is, the more money that you incur per client hour. So that's the key takeaway here, is more is better. And how you calculate this metric is you take the collections per hour, so total collections divided by total client hours equals your collections per hour. So for example, if you have $100,000 and you have a total hours spent with clients of 1,000, then your client per hour is $100. And so why does this matter? It's important for us because this really shows us how well we're doing at an individual service level. This is going to be your strong indicator at a service level of, one, your service mix, and two, how profitable each one of those service mix are, or how much contribution do they put into the mission, the critical mission of your organization. So I think also it can give the quality of care that is provided, because if a particular person is happy with the service, they'll come back and continue to utilize it. In many cases, that's good. In other cases where the state may pay you a flat fee to give care, or under a capitated model, to give care to an individual, this could be a potential problem for the organization, because they may get $30 a week to provide the service, and the person may be utilizing it 4 or 5 times a week. And that's not a problem per se. That just leads us to understand, so that we know somewhere else in the organization we're going to have to help fill in that goal, that gap there, to help us continue to be financially strong.
So looking at this data, it really helps generate an understanding of what I guess I would construe as services that drive the bottom line versus services that drive your mission. And again, coming to the right mix of those two things is really key to keeping your organization vital. Maybe those two things, services that drive the bottom line and services that drive your mission, are one and the same. And I suppose, the financially healthiest organization would have a complete equality of those two things. But I think the reality for most organizations is that isn't always the case. But you do have to understand the mix and understand how to manage that mix.
So I think the key here for that is forecasting. That's why you can look over and say, I need to be able to know what my service mix will look like a month from now, a day from now, a year from now, and how it's going to be utilized. And so that can come in. So the other thing to take away here is, when I'm looking over for best practices, I want to be able to make sure that I'm getting paid in the most timely way, and that I'm positively affecting this. And in this particular case, one of the most effective metrics here, as we can see, is that for every denial that we get, so every claim that we have to reprocess, it takes up to 280% more to process that. So in other words, for every one claim that I get denied, I have to get 3 paid the first time in order to make up for the one claim that I got denied and the amount of work that went into that. Another key element that can kind of help you out in this process is make sure you have consistent procedures, you have consistent policies that are being followed. It's not just a matter of scanning in a copy of the ID card insurance. You got to make sure you get the back of the insurance card too. For example, Blue Cross, as our favorite person here to draw an example, frequently uses TPAs. Those TPAs put the information on the claim submittal on the back of the card. So front and back salaries were required. And then it's really, how do I improve those denials? How do I drive better denials? And that's really where we get to front end.
So the bullet point is front-end system automation, but I guess in a nutshell, I'd say, how do you think upstream of the data that drives these problems? And sometimes that is policy and procedure, but a lot of times it can be system automation, and that is using things that are in your current information system capabilities to make sure you're addressing problems upstream. So, for example, you might have the ability to look at how service code combinations are entered. So, for example, can you enter a individual therapy service code at a certain location or not? Does your software support that kind of logic to box that out and say, no, we don't offer individual therapy at that location. It's only serviced at one location. If the data entry by your clinical staff can be informed that way, then you're weeding out a lot of problems upstream. And as Ben has referenced, it's a lot cheaper to fix it there than it is to fix it at the point of denial. Another example that a lot of folks wrestle with and our software addresses actually is the ability to look at service authorization check at the point of scheduling. So when you enter a scheduled appointment, do you know if an authorization exists to address that and pay for that? And again, that can save you a lot of pain and headache on the back end through that kind of upstream data checking. And so another example is the existence of a treatment plan. If you're entering services for a client that doesn't have a treatment plan, there's a good chance that's going to create a risk for you and a liability later on down the road. So the more we can looking at the front end of the process, both by policy and procedure and also training and system automation, the better off you're going to be as it relates to this metric of collections per client hour.
Yeah, that's a good point, Joe. I mean, the key takeaway here with this is let your system help manage the process, not be managed by your system. And the more you can put out the fires, forecast the fires before they happen, the less you have to put them out. And we all know that as we're trying to drown out the fires with the water, it takes us away from our critical mission, which really is to help our clients and better serve them.
And, while some of this stuff might be perceived as clinical operations, the reality is what I observe in customer organizations is the initiative is a lot of times driven by the fiscal side of the organization to say, gee, this data is what we have to effectively perform our task, and we have to have input into how that operation works. I know we see that in our RCM business as well, where we're creating claims and getting revenue for our customers, where we give them feedback on things that are happening on the clinical documentation side that drive a cleaner claim to us so we can be more effective in producing that. So our next poll question is here. And so that is, do you track collections per client hour? So if you can help us with some feedback on this question. So far, we've learned that folks in the majority are using some sort of idea of KPI. I think we were at around 55% for that. And then we at the next metric, we saw that we had about 60% of the folks doing days in accounts receivable. In collections per clinician's hour, per clinician hour, about 30% of the folks were looking at data like that. And now we see that collections per client hour. See, we save the real insightful consulting stuff for late in the game because we have a 6% adoption of this metric. So we started at some pretty broad ideas from Deming and things that a lot of people know about, but we've drilled into some things that hopefully is providing some value if folks have hung in with us here this long, with some metrics that are a little different and maybe get you some different trains of thought in your organization.
Yeah, so the takeaway here is that revenue cycle management is not just billing. It's a holistic approach to funding the organization and helping to achieve your mission. That KPIs matter because data helps drive our vision and our mission statements. And I've taught you 3 key KPIs that can be used at both a 50,000 global foot perspective and can be used at a location specific or at a service specific location. And so I hope you found this information useful.
Great. Thank you both once again for a very informative presentation. We've already had a number of questions from the audience that have come in. However, we would like to remind everyone in our audience to use the Q&A area to the right of the slides to submit a question at any time. With that, let's dive in. Our first question is, so in collections per clinician hour, are you talking about all hours that they are working, billable and non-billable activities, not simply the hours that they bill for face-to-face time?
Yeah, so I would look at that as the total billable. So if we use the caseworker as an example, the caseworker driving to and from cases should be tracked to find out where your efficiencies or inefficiencies may lie. So it's a matter of tracking all time against the collections.
And I just offer along to that, in the consulting work I've done over time, I find a real diversity of how people think about that question. Some people really do hone in on the billable time. Other folks look at it more holistically. If they're working 8 hours, we want to know about 8 hours. And Ben's take on it from a calculation standpoint was pretty purely financial. I guess I'd offer, from my perspective, for whatever it's worth, I think there is benefit to looking at it holistically and understanding what's happening for the 8 hours worked. Ben used the example of travel, and that's a great one. If someone can't make productivity and you don't know that they're in their car 4 hours a day traveling around a broad county catchment area, you don't know, and that doesn't inform your ability to open up a new service location that could lessen that travel time or change some protocols so maybe they could go from home directly to a client's house, things like that. So I think looking at it broadly does have a lot of value for you.
Great. Our next question is, for the collections per client hour, should we measure each of our services?
Yes, I think you want to look at the 50,000-foot view, and you want to be able to look at it at a more granular level at the service level component as well. That'll allow you then to see if there's specific items within a clinician's ability to earn money may be affected. So, for example, group therapy has been widely adopted to improve this particular metric. And so if you look at it from a service level between group therapy and between individual therapy, it should give you a broader perspective of what it looks like.
Great. Our next question is, for an inpatient facility, how could the collection per client hour be used? I figure it would be collections per patient per billable days.
I'm sorry, Julie, I didn't catch that question. Do you mind repeating?
Sure, absolutely. For an inpatient facility, how could the collections per client hour be used? I figure it would be collections per patient per billable days.
Yeah, I think so. For that, you want to look at the patient that's in there for the billable days. But in the day, right, I think you still look at a 24-hour or from the time that they're admitted to the time that they're discharged. You have to look at it from an hours perspective because that's what's going to drive your metric to keep it consistent if you're looking at a piece of the organization that doesn't track them in billing days. So in other words, I know in an inpatient we get paid for that 24-hour period, but you got to be able, and you're going to get paid a flat fee generally for that 24-hour period. but you need to look at it that each one of those hours contributes to 1/24th of that total fee. Otherwise, when you're comparing it to something that's billed at an hourly rate, you're not going to have an apples-to-apples comparison. Or conversely, you'd have to change all your hourly rates and make them into a daily rate to make that apples to apples. But either you look at it from hours or you look at it from a daily rate, and you have to be consistent with that numerator.
I guess I'd only add that I guess it would depend on the data you have at your disposal. I think some systems might give you more granularity and more ability to manage that. Others, it might be more a flat day rate, and that's kind of what you have to work with. But certainly, depending on how your organization runs, a lot of inpatient organizations have kind of tick charges. If you go to activity therapy, there's a charge for the activity supplies that happened in that therapy. And if you participate in another program, there may be a programmatic charge. So if you have situations like that and your information system leverages the data to look at that on a per day basis, you can probably come up with some sense of cost of client across a day. But as Ben said, I think the cleanest thing is to probably go towards a per day, and whatever you pick, stay consistent with that.
Great, thank you. Our next question is, which payer pays the quickest, Medicare, Medicaid, or commercial?
So there's a lot of data on this particular item, and it really varies from state to state. For example, California Medicaid, Medi-Cal, is the most notorious late payer in the U.S. and always has been, at least in the last 5 years. Whereas some Medicaid, like in Arizona, for example, that utilizes commercial payers to administer their commercial pay no different. But generally speaking, you're going to find that commercial payers are your mid-level payments, and Medicare generally pays the fastest, and depending on state, Medicaid might be in line with Medicare.
Okay, great. Our next question, and this will probably be our last, what is the biggest mistake providers make?
Yeah, I think the biggest mistake from my perspective, and I'm sure Joe will chime in with his perspective on this one, is to get caught up from a fiscal standpoint, get caught up in the mission and not being able to delineate the differences between that kind of service mix and understanding what drives the profitability of the business and make changes to help take the most profitable side to help fund the least profitable services and make sure that that's in check. And then next to that, it's really with training employees, trying to take on too much and not using other people to help and thinking that you can kind of do everything yourself. That's what I typically find is the biggest problem is you take on too much, you don't understand where your revenue comes from.
Yeah, I just jump on to that a little bit. And in addition, again, to the RCM services we offer, we do provide software to folks around the country that addresses their clinical needs and their billing needs. So in helping people all over the country come on board with our billing product, I think it's really a question of, are you billing by accident, or are you actually managing a billing process? So are you using a product like ours or one of the competitors that are out in the marketplace? Are you just kind of pushing the buttons, running the claims through in batch, making the machine do its job, and hoping good things come out the back end? I would say that's kind of billing by accident. You're just using the product as prescribed, but you're not really interpreting what's happening on the back end. You're not really looking at data to understand some of the metrics we've put out today and a bunch of others too, and then making insightful, informed decisions with that information to change how you use our product to maximize your result with it. Because the reality is everybody's service mix is slightly different. Everybody's payer mix is slightly different. The behavior of their payers is slightly different. And so you need to analyze and understand what's happening and then make decisions based on that. So that idea of kind of billing by accident or billing with intention and management is probably one of the biggest things I see people kind of get stuck in, either because they don't have the time, they don't have the expertise, or they haven't had the focus and the priority.
Great. I think that's all of the time we have for questions today. I want to thank Ben Pease and Joe Viger once again for an excellent presentation. I also would like to thank our sponsor, the Echo Group, for making today's program possible. Finally, thank you to everyone in our audience for participating today. We hope you'll join us in the future for another behavioral healthcare webinar. This concludes today's presentation.